Mental health is a universal concern and one highly dependent on cultural understanding. What might be seen as concerning behavior in one culture could very well be considered typical in another, and vice versa. Meantime, different countries bring different systems and policies to the mental health care approaches in their systems. So, what can mental health care professionals in one country learn by studying the work of their counterparts in other countries and cultures? And how can they incorporate those lessons into their own practices? Our guest today has some powerful answers based on his many years of mental health care work in countries around the globe. Dr. Rick Worthington is a scientist, physician scientist, currently working as a staff psychiatrist at McLean. He is trained and practiced in various cultural and geographic settings, including Germany, the United States, Ghana, Kenya, Australia, and New Zealand. His award-winning research focuses on the improvement of access to mental health services in the community, mental health-related advocacy, policymaking and capacity building, and strengthening opportunities for mutual capacity building in the global mental health space. Rick, so glad to have you with us today.
Good afternoon.
I want to start by asking you to give us a quick overview of your rather remarkable background in mental health care around the world. You grew up in and traveled around Europe and then first visited Ghana in your teens, if I've got that right. How did all that inform your work in global mental health?
Yeah, so I grew up in Germany and also went to medical school in Germany. And as part of my medical school, I ended up in Ghana and was, really impressed just by, the way healthcare was organized in a different country. It was my first time actually outside of Europe. So I was very open-minded. And at the same time, right, I looked at it, I think, through very much an efficiency lens, right? It's like, oh, all the things that don't go well in Ghana. And, looking back, I think that that's definitely something that I recognize. And at the same time, it was through my interactions, having worked in Ghana in 2010 for the first time, and then I went back to Ghana. And I kept on realizing like how much wealth and wisdom there is in the community, and, in the system. And so for me, this was really then the journey that started me to go to different cultures and contexts. And so I had the opportunity to also do my work in Kenya. I got invited to go to Australia to work there. I did my residency in the United States in psychiatry, also did a public policy degree here, was exposed to the system. And as part of my residency, eventually I ended up going to New Zealand for a few months. And so really every system is unique in its way. It has its own challenges, its own limitations, but also its own very wonderful solutions to solve issues related to mental health. And, like the last thing I say here is that when we think about global mental health, all countries are developing countries when it comes to mental health care and access to mental health care, equitable access to mental health care. And so the US or Germany are not any different than countries like Ghana or Kenya. We are all developing. And so that's really the impetus to learn from each other and to grow together and find solutions to the pressing mental health issues of our time.
I want to talk specifically about some of the work that you've done in each of these countries, and we'll do that as we go through the next half hour. Let me start, though, by asking you to run through some of the broad themes that you would put the lessons into that you've learned over the years of doing this work globally. Everything from cultural considerations to stigma. What stands out to you in terms of those big buckets that we can put these various lessons into?
So I think, when we think about mental health, like one of the terms that is very present in the United States is always like this biopsychosocial model of care, right? But there is a huge cultural component to it, and we kind of know that. And so one of the things that I really got to see is we always talk about this, but how culture actually manifests as mental health conditions, and not just mental health but health in general. Like the idea that there are many cultures around the world that don't describe mental health conditions in a similar way that we do in the United States. There's lots of research from countries in Africa or even in Asia showing us that depression would not be associated necessarily with feeling low, feeling blue, feeling nervous. It would manifest as like, not being able to sleep, having chronic back pain that is not responding to treatment, right? And so you kind of like test for all conditions that are common there, HIV, tuberculosis, malaria, and it turns out, right, it's not responsive. And so really it's a depression that manifests very differently. So that's like one of the big learnings buckets, right? The symptoms we see are very culturally bound, like the expression of symptoms, but also the way symptoms are described, right? The words that are used. There are specific cultural bound syndromes, even in the DSM-5, right? We know that some cultures have certain cultural symptoms, and that's really one of the learnings. The second learning really has to do with like how a country organizes its healthcare system, right? I think the easiest to understand is access to healthcare and insurance, right? Like there's private systems, there's government systems, there's a combination of the above. And that is really different between the countries. And, you know, there's downsides and upsides of every system, but really understanding, right, what is, you know, helpful in one system and why, and how does it, you know, translate to having access to equitable mental health care. And then I think another thing that is really different is where does care take place, right? In the US, for example, I think a lot of our care takes place in the hospital system and in office systems, like, you know, for office appointments. In Ghana and Kenya, for example, like hospitals are really expensive to manage and they exist, but most of the care, for example, happens in the community, very similar to actually New Zealand, for example. And so I think it's just like a very different approach if you think about treating someone in the community where they are, where they work, where they are from, compared to if we have someone come to the hospital. And so these are some of the like higher level learnings that I would emphasize.
How does trust factor into all of that? It sounds like that might be kind of a common thread in terms of building trust with local communities, regardless of the practices of that particular community. Is that fair to say?
Oh, I think that trust is the biggest issue, right? I mean, trust in mental health is a key issue already, because when people talk about their mental health conditions, they talk about something very vulnerable, something that is, you know, very close to them, that is shameful, that has stigma attached. So I think like, you know, trust is a very important factor in any type of like mental health work people do. But take the trust in addition to working with communities, right? Naturally, there is kind of a hierarchy. There's kind of, you know, there are factors, identity factors contributing to me, not, you know, community members not necessarily being able to trust me, right? Based on my appearance, based on my nationality, based on my gender, based on my race, based on my sexuality. And so the trust building piece is very central. And I think, you know, one of the things that I make very clear from the very onset when I'm in a new culture, you know, oftentimes I get asked, can you help us think through something, right? A policy, an activity, a research activity. And I have to be honest with them. And I have to say, I don't know if I have an answer for you. But what I can really help you with, right, is like kind of like thinking through the steps that you as a community, you as a system, you as an organization, you as the government have to undertake to find your own solutions, right? And so I think that has to do a lot with trusting the systems on the ground rather than myself. I can be the expert in this process on certain things, but by no means do I understand the cultural context or the communities necessarily well enough, and they're not even pretending, right? And so I think that's a way of building trust, and that's a way of really working with the communities and earning their trust.
So from a very practical standpoint, Rick, when you're working with local communities, whether in Ghana or New Zealand or elsewhere, what are the biggest opportunities that are afforded through that work? And what are some of the biggest challenges in terms of actually implementing some meaningful structure to that work as well?
Yeah. So I think the biggest opportunities are really to tailor mental health interventions to the local context. I think oftentimes what we see is that there is a central government, or there's like state governments or the equivalent of state governments drafting policies and trying to implement these policies on the ground. And oftentimes there's a big disconnect between those drafting the policies, those implementing the policies, and those benefiting from the policies. And really what the community work helps us to do is to decrease this gap and to make the interventions, to increase the fitness of the interventions that we propose and the activities that we propose. I think, that is one of the biggest upsides of working with the communities. And actually, one of the ways to work with the communities, again, is to say, we don't know yet what the solution is going to be, but let's just all be open-minded. Like, we know there are preconceived notions around like what's causing the problem. We know that there are preconceived notions about the solution. But guess what? I mean, sometimes, we just need to pour in money and that's going to fix it. But more often than not, right, you pour in thousands and 10,000s and millions of dollars, and the care doesn't necessarily get more effective, or access to mental health care doesn't get more equitable. And so that's when we have to say, okay, wait, let's actually pause a moment here, right? And step back and say, is the problem that we are trying to address, is the solution that we think about, is it actually addressing what the issue is? Or is there like a disconnect? And really working with the community gives us a chance of decreasing the gap and increase the fitness of the activities. The biggest downside, if you want to think about it that way, it just like takes a bit more time, and it takes, more resources, because, we have to actually work with community members. Building trust takes time, right? But I think the time is well invested, because on one hand, you can say, well, the central government can draft the policies and then try to implement them, but there's a delay because no one wants to implement them. There's no funding, there's no buy-in. Or you say, well, let's just take a bit more time at the beginning, do the drafting of the policies and the activity brainstorming on the ground level, and let the ground policies, if you do this often enough, let the ground policies then inform the federal government policies, right? In the sense that the federal government can kind of give us a frame of what the policy should look like how much care should take in the community versus the hospital system, should it be human rights based? But really, the policies are inspired from the ground. And yes, it takes more time initially, but the implementation process is smoother and quicker.
In terms of building those relationships that you need to locally, how do you go about finding who those local leaders are that are perhaps gatekeepers or influencers or conduits to folks getting the help that they need? How do you identify them? How do you approach them? How do you work with them?
I think a lot comes from actually working with patients on the ground, because they often tell us like who they would talk to and who they trust. So for example, when I was in New Zealand, there's like a couple of different, populations that are very different in terms of demographics, identity factors, history, right? There's the New Zealand Europeans, there is the Maori population, and then there's Pacific Islanders. And all of them have a very different system of like who they trust, like who they go to, right? I think oftentimes, they would tell us about the people in the community that they would trust. And that's like then the key person that we would involve. And then we would brainstorm with them to understand, what does the ecosystem look like? Who else is part of the ecosystem? And so, for example, more often than not, today's seminar is also about spirituality and mental health and religion and mental health.
Right.
And so more often than not in Ghana, in Kenya, we end up hearing, well, I came here after my pastor told me to come, right? And so then that's for us the impetus to understand better. So what happened in this referral process, right? We kind of like call it like almost like a journey map, right? Like we want to know how a patient ended up going from like being functional, having a family, being able to hold a job, all the way to like ending up at the psychiatric hospital. And so every step in the way is really important for us to understand. And we, as mental health providers, we cannot say, well, that was kind of useless for you to go, or that wasn't relevant. But we really need to understand, why do people go to certain stakeholders in the community? What makes them trust them, right? What do they get out of the relationship? What do we not offer that is offered elsewhere? And so that is really like how we engage with the community members and understand what the care system looks like and what people we need to engage with.
I would love to hear about any specific examples you can provide from New Zealand, from Kenya, from Ghana, Germany, the US, in terms of breakthrough moments for you, those aha moments where you said, wow, this is something I hadn't considered before. There are cultural, spiritual, religious identity issues here that I hadn't thought about. What were some of those learning moments for you?
Absolutely. So we, give an example from Ghana, where we have been working with religious leaders for a few years now, and not only religious leaders, but also traditional healers. And so, there's a lot of, um, you know, there's competition, right, between medical professionals and spiritual leaders or traditional healers, because at the end of the day, it's kind of who gets picked and who gets to see the patient, right? And so there's lots of competition, but we managed to actually bring the same people to the same table talking about patients with mental health conditions and how we can make the system more accessible and how can we actually work together. And so one of the things that really stood out to me was a workshop where we were teaching mental health professionals about spirituality, about religion, and how it impacts mental health, and where we taught religious leaders, traditional healers, spiritual leaders about mental health. And I remember very vividly that we discussed the case of a young gentleman with epilepsy, which is in Ghana, it falls under the umbrella of psychiatric conditions. And, we talked about epilepsy from a very medical, almost like westernized perspective, right? How we see it, what we think is happening. And the traditional healer started talking about his perception. And so it was, as you can imagine, it was quite a different approach to the same condition. And what was interesting is once we got to the treatment part, one of the things that the mental health professional shared was, if someone has a shirt on or clothes that, can impact your airways, let's take off the clothes, right? So that someone can still breathe. And the traditional healer said, it's funny that you guys do that because we do exactly the same, but we are doing it to actually let the bad spirit leave the body. Right. And so at the end of the day, it was very insightful for everyone involved to hear why we do what we do and why we do it. But what was even more insightful was like, let's focus here on the patient, right? It's not about the competition between us. It's not you're right and I'm wrong. It's really about how do we not harm a patient and how can we work together? How can we collaborate? And that is really what we were able to focus on. And that is really what built the trust between these professions because they were able to talk with each other about their experiences and what to do and what not to do.
You were trained with a very Western framework, as you've suggested. How difficult was it for you to be in other cultures with different beliefs and not just want to put that, not just want to filter everything that you were doing through that lens of the Western training you got? Was that difficult?
Absolutely. And it continues to be a challenge, right? I think there is a lot about cultural humility. There's a lot about, a lot of things that I don't know about. Of course, as a researcher, I understand that, when I work in other countries, in the world, we are taking the DSM-5 or the diagnostic criteria, the ICD-10 or 11, we're taking it, right, to a different context and say, okay, let's just use it, right, to teach, to do research. And at the end of the day, we have to acknowledge that the countries in which we're using it, they were not necessarily involved in the drafting stage of these manuals. And so their voice has not been heard. And yet we're going to these countries and kind of try to apply, right, these diagnostic manuals. So the next best thing that you can do then is to say, okay, how can we support local research to kind of like come up with something that is unique and fitting for the local context, right? Or like, how can we take questionnaires that have been designed in like countries like the United States or Germany, and how do we make them culturally relevant to a context like Ghana and Kenya? But, I recently actually had a discussion with one of my colleagues from New Zealand about, for example, CBT, cognitive behavioral therapy. I think from that model, again, was developed in Westernized countries and obviously has a lot of different influences, right? Some of them are religious influences, some of them are coming from other areas, but really it's the idea that, your thoughts are connected to your emotions and your emotions and your thoughts are connected to your behavior, right? And so in the spirit of translating this to a different cultural context, you would then say, let's take this framework and translate this culturally to your respective context. But I'm not even sure at this point if that is the most appropriate because different cultures think about health very differently. They don't think about the connection that thoughts are connected to emotions or behavior in a similar way that we think about it. And so it is really, we need to rework this whole framework, this whole blueprint of CBT, if we really want to be culturally sensitive. And that is hard because that again takes time and a deep, deep understanding of someone's culture, right? And again, for example, in New Zealand alone, there's like many different cultures. And even within the same culture, let's just say the Pacific Islands, there's a couple of, different Pacific Islands. There's Samoa, there's Tonga, right? There's Nui, and so on. And so each island has its own model of like how they explain health on very different levels. And so I can't just take things from the West and culturally adapt them. I mean, that's the next best thing to do. But really, if I really want to be culturally relevant and appropriate, I have to understand how people think about health and disease in their respective contexts without any preconceived notion what I think health is. And that is incredibly hard to take off after decades of having been trained in a Westernized system.
Rick, I want to use the rest of the time that we have here today to talk about applying some of these global lessons to work here in the United States. I've sort of picked up from you that there is much more of a bi-directional exchange of information available than we in the West might think to be the case. We might be unilaterally looking to take our frameworks and impose them on other cultures, for example. What have you learned that you are applying in your practice today in the United States that's come through this work that you've done with other cultures?
Yeah. And Jeff, I think that's a very important question. And before I go into one specific example of what we have learned, let me just say that I do think that currently one of the things that we in the United States are suffering from is that we are very short-sighted, and we think that the healthcare system here, when we think about working internationally, we oftentimes think about, well, what can the US teach other cultures and countries? But I think the reality is that the US has more to learn from other cultures and countries than the US can actually teach other cultures and countries. And I say this with a lot of humility and respect. But I also say this because I notice that oftentimes when there is a gap, when we don't know what we need to do, right, we say, well, we need more research. But hundreds and hundreds of papers have been published in low and middle income countries that actually give us the answer. So instead of redoing some of the research, what we rather have to do is use an implementation science perspective and see like how can we actually apply what we learned here in the elsewhere in the United States. And I say this, I give you an example. I used to practice in North Carolina before moving to Massachusetts, and North Carolina has 100 counties, and about 2/3 of these counties do not have a single psychiatrist. And functionally, while North Carolina, as we all know, is in the United States and counts as a high-income country, functionally, North Carolina looks like a low and middle-income country in terms of access to mental health care. The second thing I want to say before giving you the example is that we always talk about, when we talk about international work, we always talk about post-colonialism, right? And there's an understanding that, that's the mindset and that's what we need to do because, we need to create equity. And the reality is that who is represented at international conferences, it's mostly people from the global north talking to people from the global north about people from the global south because of visa issues, because of financial challenges, right? But even on a smaller level, like who gets to publish what research in what articles, who gets to own the data, right? And so oftentimes what is done is we extract, once again, research from low and middle income countries and try to apply them to the United States. And then we say, well, that's, post-colonialistic. There's nothing about nothing about post-colonialism. That is extracting data from our colleagues in the low and middle income countries that have less access to research that we do. But one specific example that I have been working on with my colleagues from Ghana and Kenya is the idea of community mental health workers. So the idea of there will never be enough psychiatrists or psychologists, and they're also not necessarily working in the communities. So how can we actually fill the existing treatment gap and the access issue to evidence-based mental health care. And again, there's in the United States, there's lots of safety concerns and there's lots of legal concerns, which I think they're all valid, and I think we need to think about them. And at the same time, we have hundreds of papers from low and middle income countries like Mozambique, like Ghana, like Kenya, showing us not only the effectiveness about interventions carried out by community health workers, but also the safety of these interventions. And, we have learned exactly how we need to train them. We have learned about the referral system, what happens if someone shows red flags. We have learned what psychotherapy ingredients, right, we need to offer, what they can teach to target community members that experience mild to moderate mental health conditions or common mental health conditions. And so that is something that I've been working on with my colleagues from Ghana and Kenya here in the US, because I really think that we need to alleviate the mental health workforce shortage by increasing the pool of qualified mental health providers. And I really do believe that some of these mental health providers need to be in the community where people live, where they work, where they have their families. And community health workers, as they are used in Ghana and Kenya, are very well positioned to close the current treatment gap.
Real quickly, do you find that there's more interest in this topic in the dialogue that you're a part of now than when you started out umpteen years ago doing this work? And what is the trend line with this?
There is more dialogue around it, and there's also a lot of siloing. Lots of institutions have connections to stakeholders in low and middle income countries, but they don't talk to each other. So there's a lot of money spent, but it's lost money. There's not a lot of what did we learn? What did you learn? Communication. And there's still very much room to improve to, again, include our people, our partners and colleagues from low and middle income countries in this conversation.
Rick, I am afraid we are out of time. This half hour has just flown by, but wow, what a great set of real life lessons you've just shared. And what a powerful reminder of why it's so important for all of us to continue exploring the critical connections between spirituality, culture, and mental health. Thank you again for your time.
Yeah, thank you too for having me.
Dr. Rick Wolfison.